Hello there, once again, welcome back. Today we'll build on our discussion. Last time it was basic biopharmaceuticals. Now we'll talk about what affects drug activity. That's pharmacokinetics and ADME that we covered last chapter. So if you haven't watched those videos, make sure you do so because we're going to build upon those topics. If this is your first time with us, then welcome. But if you're coming back, thank you for hanging out. Okay, this is going to be a three-part series. So this first one's just introductory. We're talking about different life stages and the various effects of those life stages. Human variability, things that will affect drug disposition. And that's absorption, distribution, metabolism, and excretion. So for us neonates, brand newborn babies are going to be that first month of life. An infant, after that first month, up to 1 year or 2 years, depending on your reference book. So in this text, they say about 2 years. Then we have our children, about age 2 to 12, or at the onset of puberty and or body size. That would determine when a child's still a child or should be considered an adult. We have adolescence, major changes due to the hormonal levels of puberty, 13 to 19. Next, the adults, and then after 70 years of age, we have the elderly geriatric patients. Neonates and infant, very different because of the underdeveloped organs. Less efficient in drug elimination. So if you remember, that is both metabolism and excretion. So both the liver function and kidney function. Lower protein binding. So this occurs in the blood. So this will affect distribution. As mentioned in lecture, warfarin is about 98% protein bound in the blood. So in this case, there's just going to be more free drug in the neonate or infant's body. Already mentioned immature liver function and an immature blood-brain barrier. As you recall, this is not a physical barrier. It is just the neuroglia cells, so the helper cells in the brain that controls what chemicals, what compounds enter into the brain. Children, so about ages 1 to 12, 2 to 12, they're going to have a much higher metabolism. And that's because of the smaller body size. They're going to be radiating a lot of heat. So a lot of heat loss, a lot of growth. So very rapid metabolism during these ages. So that means faster metabolism, means faster drug excretion. So it's going to be a little bit counterproductive. But for these drugs, clindamycin, antibiotic, valproic acid, anti-seizure med, and then theophylline is a bronchodilator. So for children, you'll actually need to increase these doses because they excrete it extremely fast. Next, we have our adults, 30 to 70 years old. So it's a steady decrease in physiological function. So that means lower cardiovascular output, lower liver function, lower kidney function. And then we have the elderly. They may or may not be dealing with multiple chronic diseases, and in that case, taking multiple medications. And this is where drug therapy becomes dangerous, when you're taking 3, 4, 5, 6 medications. Not only missing doses, but the drug interactions that can occur. Slower absorption because of gastric emptying time. So the food stays in their stomach just a little bit longer, promoting drug degradation, delaying absorption into the blood. Slower distribution. Once the drug is into the blood, that lower cardiac output will take a little bit longer distributing the drug to the site of action. And then their lower kidney function will decrease excretion and ultimately elimination. Review questions. What are the ages of children? If you mention 2 to 12 or 1 to 12, that would be correct. Who has the fastest metabolism? Which age group? Which life stage? Yep, that would be the children around ages 2 to 12. Smaller bodies, losing lots of heat, growing rapidly. Gender differences that will affect drug disposition. So in your book, you'll have a complete list, but I'll just mention a few of them. So hormonal fluctuations. So for women, they're fluctuating between estrogen, the female hormones, and progesterone, the male hormones, throughout that menstrual cycle. Men generally carry more muscle, whereas females carry more fat. Now, what's important is the volume of blood. So in fatty tissue, there is not a large blood supply. There's veins running through. But definitely in the muscles, there's a large volume of blood. So since there's more blood in the male body, the drug can be diluted out more. Many changes during pregnancy. So as the womb grows, the rest of the body needs to move out of the way, and the internal organs actually will atrophy, get a little bit smaller to make room. So the stomach gets squeezed, pushed up into the chest. So no longer large meals, but a bunch of small meals. Increase motility in the digestive tract. You're going to get reduced protein binding, so that means more free drug. Increased urinary excretion. That's because the bladder is also constantly being pushed, and it does get a little smaller. And then higher drug concentration in the fetus. So a lot of chemicals exposed to the mother will enter into the fetus. However, the placenta does filter out HIV and other small compounds. Human variability. The last one, we'll talk about genetics. So your genes are what codes for all your proteins, and in this case, proteins are our enzyme, our protein catalyst, our enzyme catalyst. So if you have the DNA but are not able to express it and make the proteins you need, that may cause a disease state. And in many instances, that is the cause of the disease state. For example, lactose. So lactose is a sugar, and we do have the gene to produce the protein that breaks it down. That protein is lactase, that enzyme. It converts lactose into sugar that we can use. However, at some point when we become adults, some of us lose our ability to produce that protein, and then we become lactose intolerant. Metabolism, definitely. Some people can eat all they want and they'll burn it off. Other people, if they just smell the food, they'll gain a couple pounds. And lastly, body weight consideration. For infants, definitely smaller body size will dose based on their body weight. Also with children, in Math 5, I cover Fried's Law and Clarkson-Young's Law for the estimation of pediatric doses. Emaciated, so if you're super thin, and if you're overly obese, and they're saying upwards of 30% body fat or more. So if you're emaciated, definitely we'll need to reduce your dosage because of lower body weight. And for obesity, we'll have to actually give you less drug because remember, there's no blood supply in the fat. So the drug will not be entering where the fat tissue is. The placebo effect. So we all heard of the sugar pill. So this is a psychological factor. People think that they're taking a tablet that's beneficial. They feel good about it. And that produces a positive outcome, even though the drug is inactive. All right. That brings us to the end of part 1, factors affecting drug disposition. Up next, we have part 2, where we'll start getting into some adverse drug reactions and how they differ amongst different patient populations. Once again, thank you for joining me, and I'll see you next time for part 2. Once you go Fong, you never go wrong.